tidal percussion, liver dullness, upper body reason.
So palpation, you said organs are palpable. So how to look for the splenomegaly? In simple cirrhosis, the book description is there will be hepatomegaly, splenomegaly. Early cases. Late cases there will be shrunken liver. So the liver, of course, liver conventional, we can come from the right iliac fossa, 2 centimeters with each attempt to go up towards the right hypochondrium and palpate the liver, whether it is palpable or not. Spleen. So the conventional method is going from the right iliac fossa towards the left hypochondrium. But in presence of fluid, you have to use the method, the so-called dipping method. So what is the purpose of using this dipping method? You are not using the dipping method for the palpation of the liver, not for the kidney or some other organ. This is specifically advocated for the palpation of a spleen. Why? Because so the dipping means you have to see like this, gently press it like this and see anything is touched by your fingers. So the point is when you push it like this, many people say that you are displacing the fluid, so that the spleen is palpable. You are displacing the fluid, no doubt, but the other aspect is because the spleen is suspended in the abdomen by means of the 2 ligaments. It is connected to the stomach and kidney. So it is not a fixed organ, it is suspended in the abdomen by virtue of 2 ligaments. So when you push it like this, what happens is the organ also goes down like a ball. So immediately it bounces back and touches your fingers. So that is the reason why you use this dipping method. So it goes down and bounces back and touches your fingers. So that is the idea behind it, why you have to use only the dipping method, not the other methods. So fluid thrill, it is present here. The method of examination. Okay, I have to put a hand like this. So vibrations will be transmitted and it was felt if there it is present in this case. Yes.
Percussion, sir. Tidal percussion. Upper liver dullness, upper body reason the 50 intercostal splits, lower body dullness merged with the dullness of fluids.
Why not we do tidal percussion here? See, percussion is done to know what? Liver. So the percussion is meant here because in the palpation you said the liver is not palpable. Yes? So the other way is to find out the liver size is by percussion. So you percuss from above downwards and see where is the upper border. Okay. Again you percuss from below and see where is the lower border. So did you make out here the lower border and the upper border? Upper border in the 5th space, lower border merges with the dullness of the 2nd, 3rd, 4th. It is dull. Then take on the magnet, it is resonating together. It is resonant. Why you say that it is not made out? So here is the upper border. So when the dull node ends here, you can take it as a costal margin as a lower border. So here it is resonant only. So if it is continuously dull, if there is no distinction made out, then you can say because the fluid is there, the dull node is continuous, I am not able to make out the lower border. Otherwise, you can take where the dull node ends here, it's a lower border. This is the upper border. You join these two, measure the height, that is the liver span. So how much liver span here, you make out this, measure it, see. So చూడండి ఎంత ఉందో. So what normal liver span is 12 to 15 centimeters. If it is more than 15 centimeters, I have to say it is hepatomegaly. Less than 10 centimeters is shrunken liver. This particular physical finding is very vital in the examination of the GIT. For the reason, in no other condition you made out the shrinkage of the liver except in cirrhosis. So if you make out the shrinkage of the liver, it is a point in favor of cirrhosis. So you will have a very good clinical evidence to say that this is a case of cirrhosis. In no other condition you will have shrinkage. So it's a very important sign to make out. So remember that always you should make an attempt to see the liver span. Don't forget about it. It's very, very important. So there is one thing is percussion, the other thing is shifting dullness. So is it present here? Shifting dullness. So again, how to, sometimes you will be asked to demonstrate it. So percuss from above downwards like this. See, still some air is there, that's why we are getting resonant here. So it is dull, is it? See, earlier it was dull, it is resonant. Okay, now we go on percuss the other side. Now it is a dull, is it? Keep up with the low. So the test name is shifting dull node. Earlier it was dull here, now it is resonant. Earlier it was resonance here, now see. So the dull is shifted, not the resonance. That's why it is called a shifting dull node. You have to demonstrate this dull node is shifted here and this dull node is shifted here. That means fluid is shifting, it's not the resonance. Okay. So both sides we should demonstrate, then only the test is completed. So paralysis sign means you have to keep the patient knee elbow position or the chest position. Again you percuss from periphery towards the umbilicus, and around this you may get some dull node somewhere here, and at the interface of this dull node and the resonance you have to put a stethoscope there and then percuss and listen to it. So that the puddling noise, if you listen, that indicates there is a fluid. So there is not that much reliable sign. So among all these three, there are minimal fluid is there, you can make an attempt of it. But among these three signs, the more reliable sign to say that there is a fluid is the fluid thrill. So to say that the fluid is there in the abdomen, there are three things for you, three clinical tests. One is fluid thrill, the other one is shifting dullness, the third one is paralysis sign. Still there is a minimal fluid is there, we can go for ultrasound examination. That can pick up with minimal fluid. So unless 1 to 2 liters of fluid is there in the abdomen, clinically it may not be demonstrable. So when small quantity of fluid is there, till ultrasound can be done to demonstrate the fluid in the abdomen.
Auscultation, vowel sounds are not heard, no vascular bruit, no venous leak. Other system examinations, sir. Respiratory system.
So one is the bruit generally, or sometimes a rub whenever there is increased vascularity, especially over the liver. Sometimes it can be present. So the venous hum, where do you look for the venous hum? So what is the reason why you will have that venous hum? So the systemic anastomosis, opening up of umbilical veins. So if you put your stethoscope there, there will be venous hum. What do you call that venous hum if you listen? It goes by a name. Cruel here, Van Barton syndrome. Okay.
Other system examinations, respiratory system, vesicular bed sounds are heard, no added sound, cardiovascular system, S1, S2 heard, no murmurs.
So in the respiratory system, we have to focus on two important things. One is there any crepitations at the base of the lung? Because of the lung congestion, there can be crepitations. The other important thing is there can be fluid in the pleural cavity. The so-called hepatic hydrothorax is common on the right side of the chest. In 10% of the individuals, there can be pleural fluid collection on the right side. So, allow the breath sounds absent on iron. That we have to look for carefully. Cardiovascular examination, again, you have to focus on the examination for the reason that there is an entity what we call cardiac cirrhosis. So the etiological factor may be in the heart itself. We have seen the rise of GVP here. The important cause of cardiac cirrhosis is any underlying cause that results in chronic right heart failure. So acquired heart disease is more common. It could be mitral stenosis, or it may be restrictive cardiomyopathy or constrictive pericarditis. So when you are examining the cardiovascular system, you have to keep these things in the mind and then look for any signs suggestive of these heart diseases. And there can be, in the form of a complication of cirrhosis, there can be portopulmonary hypertension. So I have to look for is there any sign or signs of portal hypertension? So are the effects on the parasternal lift on the P2 loud on the okay, it's not just telling S1 is too normal. Yes.
Central nervous system examinations. Patient is conscious, coherent, tone is normal, reflexes are present, no focal neurological deficit. Conditional diagnosis.
So again, in the neurological examination, we have to keep in mind in the history we asked any sleep alteration. The physical findings you have to verify whether again the fetor hepaticus is there or a flapping tremor is there. What is the plantar, whether it is upgoing or not? What is the tone of the muscle, whether it is increased or not? What happens to the DTR? Deep tendon reflexes, maybe increased, tone may be increased, plantar may be upgoing, asterixis may be there, and fetor hepaticus. They are all signs of hepatic encephalopathy. And again, constructional apraxia. Any altered sensorium is there or not? In a conscious patient, sleep alteration may be there. Constructional apraxia. So you can give some exercise for him, giving some numbers, joining them, asking him to try like a star, like putting a clock and then put the numbers correctly like that. So how much he is able to do it. So constructional apraxia can be a feature of the early encephalopathy. So keeping this in mind, I have to examine the nervous system, not just telling it's normal. Yes.
Provisional diagnosis. Chronic decompensated liver disease of alcoholic etiology, probably cirrhosis of liver with portal hypertension.
Chronic liver disease, cirrhosis. So you can say alcohol related chronic liver disease, probably cirrhosis. Any complications are present here? You said only portal hypertension is there. Yourself failure only the. What are the signs of portal hypertension? You said with the signs of portal hypertension. Tell me the signs of portal hypertension you have encountered in this patient. See, what you are seeing here is that it's a triad, very important signs. One is a dilated or distended, dilated veins over the abdomen with flow away from the umbilicus. They use the same words. Distended, dilated veins with flow away from the umbilicus. Number one. Second thing is presence of ascites. Third thing is splenomegaly. Right, it should come like that. Three signs. So splenomegaly would not make out. Veins are the ascites is there. There is an important theory what you call underfilling theory. Underfilling theory. So what this theory says is, because there is a increased hydrostatic pressure here, decreased oncotic pressure is there, so the fluid seeps out from the splanchnic belt into the peritoneal cavity. So for this, there is increased resistance in the liver, there is a photosystemic circulation, there may be release of the vasodilators in the form of nitric oxide, there may be hypoalbuminemia, there may be role of prostaglandins, kallikrein, bradykinin alteration, and even the other things like increased sympathetic activity. So many factors have been attributed. So the basic thing is there is increased hydrostatic pressure, decreased oncotic pressure, and migration of the fluid from the splanchnic belt into the peritoneal cavity. So when there is a migration of the fluid into the peritoneal cavity, a situation like hypovolemia is created inside the blood vessels. So that's why these people are hemodynamically very unstable. There is a lot of fluid everywhere, but there is a hypovolemia inside the arterial vessels. So when there is hypovolemia, the perfusion to the kidneys will be decreased. So when there is oligemia to the kidneys, there is an activation of a renin-angiotensin system. So it triggers again the secondary hyperaldosteronism. So activation of RAS will take place. As a result of which there will be secondary hyperaldosteronism. So this causes fluid and water retention. So that's why you see the edema, the other parts as well, not only the abdomen. So it causes sodium and water retention by the distal tubules of the kidney. So that's why there is ascites. This is the most valid theory that has been put forth. So the other theories like overfilling theory, hepatic lymph flow theory, and role of prostaglandins, the other hypoalbuminemias. So many other things are there. The most accepted theory is this underfilling theory. So the mechanism, how the portal hypertension produces the ascites, we should know. So your diagnosis is alcohol-related chronic liver disease, probably cirrhosis. If any complications are set in here, you can add to that. Say there is an encephalopathy, there is a GI bleed, spontaneous bacterial peritonitis. I was telling that there is a pain, temperature, you have not accounted it into the diagnosis. So there would be SBP. So the history, so we can still entertain whether it is there or not. Okay. So any complications are there, you can add to the diagnosis. Right? So alcohol-related chronic liver disease, most probably cirrhosis of liver. That is the approach diagnosis. So when you are arriving at the approach diagnosis, why you want to say it is a cirrhosis? So what is the clinical evidence? So we have to document this. Number one is we want to make sure clinically, basing upon the history and the physical findings, that it is a case of cirrhosis, we should be able to demonstrate the two sets of signs. One is we should show the evidence for the liver cell failure. So what are all the liver cell failure that the patient is having in a given case? They have a checklist and then verify how many of them are present. So I enumerated that there is a venous dilation, ascites and splenomegaly. So how many of them are there? So you document. So when you have both signs in support of liver cell failure and portal hypertension, it is clinically nothing else than cirrhosis only. Sometimes you may have only ascites presentation or only splenomegaly or sometimes hepatosplenomegaly. Still the possibility of cirrhosis can be entertained. Because the ascites, as I said, it can be a sign either because of the liver cell failure or portal hypertension. In a given case, you don't know what is the reason. So still you can entertain cirrhosis as one of the differential diagnostic conditions. Similarly, splenomegaly. Splenomegaly again can be due to portal hypertension. So we don't know whether this portal hypertension is there in this patient which is as a result of cirrhosis. The other thing is hepatosplenomegaly. So both can be present in cirrhosis. So, in other words, the clinical presentation would be a classical one, as you see in this patient, where the patient is having both signs of low cell failure and portal hypertension. That is a classical number one. Second thing, it can be only ascites, or it can be only splenomegaly, or it can be hypersplenomegaly. So, whenever you come across these things, one of your differential diagnosis should be 06. That is clinical presentations. Now, having seen this patient, how to proceed further? So you made a provisional diagnosis of 06. What investigations you would like to? So any patient wants to make a provisional diagnosis means they have to confirm it before you take it further for the treatment. So the workup should be complete. We should thoroughly investigate the patient and thorough assessment has to be made. Then it is easy for you to treat the patient and have a plan to give the prognosis of this patient. So, in the initial workup, what you have to do is in this patient to start with the urine examination. So, urine examination, bile salts, bile pigments can be present. Urobilinogen can be present in this case. So, it may be liver related. On the other hand, the patient may be having diabetes, urine sugars, you can see, or there may be albuminuria. So, the swelling, because it is there, you can't say simply it is liver disease, it can be a renal problem or it can be diabetes. So, these things can be excluded. At the same time, urobilinogen, bile salts and bile pigments can be used. Blood investigations, so simply doing a HB completed blood counts like that, the hemogram would be ideal because most of these patients will be anemic. So, for various reasons, there can be GA bleed, there can be coagulopathy, so there can be bone marrow depression, there may be toxicity over the bone. So many things can contribute for the anemia. So the anemia, most likely one can encounter is iron deficiency anemia. Now, sometimes there may be other deficiencies as well as folic acid as well as B12. So there can be megaloblastic anemia. Or sometimes it may be dimorphic anemia, both components may be present. Or sometimes it may be hemolytic anemia as well. So there is an entity what we call Jews disease, acanthosis, sparse cells, hemolytic anemia, especially in alcoholics. It is very common. So anemia means in these patients it could be either iron deficiency or megaloblastic or dimorphic or hemolytic. Anything would be possible. So have a hemogram. That will be ideal. Simple hemoglobin may not be helpful. Therefore, smear you have to see whether it is microcytic or macrocytic. And other investigations like ferritin, B12, folic acid. So these things also will be useful when you are treating the patient. So for every patient, if you don't give iron, it may not be useful. You have to identify correctly the diagnosis and then proceed with the correct treatment so that the patient can improve. So hemogram is one important thing in these patients. The other important thing is LFT, liver function test. So there can be jaundice, you see the bilirubin levels. Okay. The other important thing is the liver enzymes. So liver enzymes, what is the role of liver enzymes in the cirrhotic patients means there are three important enzymes for you. One is alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase. So these are the three important enzymes. By estimating these three enzymes, you can say whether the patient is having a medical jaundice or a surgical jaundice. If it is a parenchymal disease, you will have an elevation of ALT and AST. If it is an obstructive jaundice, the patient will have an elevation of the alkaline phosphatase. By simply looking these three enzymes, one will be in a position to say that it is a parenchymal liver disease that the physician is dealing with it, or a surgical jaundice. Surgical jaundice may be having a number of other causes. So, as a screening method, also it differentiates whether the patient has got a gallbladder pathology, stones on the cancer on the pancreatic carcinoma on the hepatocellular carcinoma on the secondary. So many cysts on the abscess on the surgical causes you can exclude by simply doing these things. And another advantage is you take the ratio of the AST by ALT. AST by ALT. So these two things will be elevated in a parenchymal liver disease. Now you say that it is an alcoholic liver disease. Somebody says that he had jaundice 10 years back. It can be a viral etiology. In fact, in our setup, both are common. So both the viral etiology would be a little bit more compared to the alcohol, but both are important etiological factors. So when you take the ratio of the AST by ALT, if it is more than 2:1, it goes in favor of alcohol etiology. If it is 3:1 or 4:1, you can emphatically say that this patient is having a alcoholic liver disease, in spite of the patient's anemia. So that is the significance of the enzymes in a liver disease. So you can say whether it is medical jaundice or surgical jaundice, whether it is because of the viral infection or alcohol etiology. So that information will be there with you if you estimate these three enzymes. Okay? So I have to interpret, you should know the normal values also. ALT is 5 to 50 units per liter. AST 5 to 45 units per liter. Alkaline phosphatase 40 to 125, again international units per liter. But lab to lab variations may be there. You have to see the standardization of the lab when you interpret these values. That is again very important. So sometimes there may be, say for example, ALT, suppose 50 is the upper normal limit. Sometimes it may be around 60, 65. So is it a significant elevation? So the number of studies to say what is the significant value of these enzymes. Many authors say when it is more than 3 times of upper normal limit, you have to consider it as a significant elevation. But in a case of cirrhosis like this, what we see in practice is there is an element of liver cell failure, that means parenchymal liver disease. On the other hand, there is a loss of architecture, cholestasis, there is a little bit obstruction as well. So what you get in a cirrhotic patient is all the 3 enzymes will be elevated, though not to the extent of pure parenchymal or obstructive lesions. So a mild to moderate elevation of all these 3 enzymes is possible in a case of cirrhosis. Both AST, ALT and ALP will be increased to mild to moderate. So in other words, when you estimate these enzymes, your inference will be probably this patient may be having cirrhosis, nothing more than that. So it is not going to confirm or disprove your diagnosis by doing it. This is the information what you can have. Okay. The other important investigations are serum proteins. That is total proteins and serum albumin. So because it is synthesized in the liver, there can be hypoalbuminemia. It is one of the prognostic factors as well. So serum total proteins and albumin has to be estimated. What investigations you have to do? What would be the underlying etiology? So what etiology you are suspecting? Keeping that in mind, you have to order a lot of investigations. Suppose you say autoimmune hepatitis is the cause of the cirrhosis. You have to do some other investigations like anti-nuclear antibodies, anti-smooth muscle antibodies, anti-mitochondrial antibodies, immunoglobulins. It all depends upon the underlying. So sometimes you may ask what is lupus hepatitis or lupus hepatitis, may be a question. So it is autoimmune hepatitis called lupus. Okay, like that.